Yes, Mr. Pavan is there?
Praveen.
Mr. Praveen.
Sir, good morning.
Good morning. Good morning. So I take this opportunity to once again thank Alchem and its team for supporting us. Okay, thank you. So once again, welcome to the teaching class of Department of Urology, Savai Mansingh Medical College, Jaipur. Today we have a presentation on pyelonephritis, which includes acute pyelonephritis, emphysematous, and xanthogranulomatous pyelonephritis, and its management. This would be presented by our resident, Dr. Rajat, and would be moderated by our faculty, Dr. Neeraj and Dr. Manoj. So I would request Dr. Rajat to kindly share his presentation. Go ahead.
Good morning to all of you, very warm. Today, I'm glad to share my seminar on the topic kidney infections, pyelonephritis. Pyelonephritis is a term usually referred for kidney infections, which is an inflammatory process involving the kidney parenchyma and the renal pelvis, usually secondary to a bacterial infection that arises from the lower urinary tract. Kidney infections usually occur when the bacterial flora migrates from the skin or the bowel through the urethra to the bladder and undergoes uroepithelial penetration, followed by ascension by ureters into the kidney, resulting in acute pyelonephritis, which is often complicated by acute kidney injury, resulting in the complete shutdown of the kidney requiring ICU support. So there's an older classification for UTI into complicated and uncomplicated. Earlier, they used to include healthy, non-pregnant women of reproductive age group with a normal urinary tract function in the structure. In uncomplicated and complicated cases includes risk factors such as male gender, pregnancy, children, postmenopausal, and those with a structure function abnormalities such as stone, obstruction, VUR, or catheters, and also including comorbidities such as immunocompromised or poorly controlled diabetes. But this has been wiped out by a new updated UTI classification framework given by Infectious Disease Society of America. They said that the uncomplicated UTI only includes infection confined to the bladder in afebrile men or women, and the complicated UTI refers to the infection beyond the bladder in women or men. Therefore, men is no longer a complicated UTI risk factor. And this includes pyelonephritis, febrile or bacteremic UTI, catheter-associated, and prostatitis. When the topic is about pyelonephritis, the pathogen prevalence plays an important role. E. coli stands at rank 1 in both uncomplicated and complicated infections. But in complicated infections, other gram-negative bacteria also plays a very major role, including Enterococcus, Pseudomonas, Klebsiella, Proteus, and that's why it is mandatory to initiate a broad-spectrum antibiotic coverage in case of complicated UTIs. Now, kidney infection usually occurs when there is an imbalance between bacterial virulence factors and the host defense mechanism. Bacterial virulence includes three main important factors: P. fimbriae, type 1 pili, and urease. P. fimbriae particularly binds directly to the renal epithelium, therefore responsible for 90% of the cases of pyelonephritis, and type 1 pili binds specifically to uroepithelium, responsible for cystitis. And urease produced by Proteus, this causes alkalinization of the urine, triggering the formation of Stubaitis type 1 calculi. On the other hand, we have a host defense mechanism that prevent the infection, which includes TAM horse full protein, which is secreted by the ascending limb of the loop of Henle to prevent attachment of type 1 pili. Gag layer protecting the mucous membrane, as well as lactobacilli lowers the bacterial pH, therefore lowering down the pH. Urine characteristics such as high osmolarity, low pH, and normal anticate flow is also a physiological function from the host defense mechanisms. So after coming up with the suspicion of a patient with pyelonephritis, urine analysis plays a very important role, giving it two reactions: nitrite testing and the leukocytosis. Gram-negative bacteria converts nitrates to nitrites. This combines with the aromatic amines to produce diazonium salt, which is getting a pink color, having a high specificity, but can have false negatives with gram-positive bacteria, Pseudomonas, and also when the urine is held in the bladder for less than 4 hours, that is an overly dilute urine. And if a sample is positive for both the nitrite test and leukocyte esterase, there is a sure shot that 80% of those will yield a positive mid-stream urine cultures. Now, the absence of pyuria should always question the diagnosis of UTI, because an inflammatory reaction almost always triggers a WBC response, Therefore, it is very rare to have an pyuria without a cause of UTI. Defining a significant bacteria, there are three methods of urine sample collection. The first one is suprapubic aspiration, the second is catheterization, and third is clean catch midstream urine sample. In case of suprapubic aspiration, any amount of gram-negative bacteria or concentration of gram-positive more than 10 power 3 gives you a high probability of significant bacteria. In case of catheterization, if you're getting more than 10 power 5, it is high probability. And if you're getting between 10 power 4 to 10 power 5, this is likely a diagnosis of significant bacteriuria. And in case of clean catch, in case of men, it is more than 10 power 4 colony forming units. And in case of women, depending on the symptoms, if it is a symptomatic woman, single episode of more than 10 power 5 CFU can give you high probability, though IDSA allows lower threshold for asymptomatic women only. In case of asymptomatic women, more than 10 power 5 CFU on 2 consecutive specimens give you 90% probability. The norm is that you should never treat asymptomatic bacteria in the general population. Treatment should be reserved only for high specific population, such as pregnancy, children, and any procedure urological which is having a risk of mucosal bleeding. As we have seen that acute pyelonephritis can have two routes of infection, ascending route and the hematogenous routes. Ascending route is usually taken by most of the organisms, but hematogenous route is usually shared by Staphylococcus aureus and Mycobacterium tuberculosis. This due to the edema from the cystitis alters the eutrophysical junction, permitting the retrograde ascent. Important thing to note down is the sequence type ST131 is actually emerging as an MDR threat in acute pyelonephritis. Acute pyelonephritic patient presents with a clinical triad of fever with flank pain and costovertebral angle tenderness, as well as uncontrolled nausea, vomiting. And this pathology behind acute pyelonephritis, this patchy infiltration by the neutrophilic exudate, resulting in the small cortical abscesses development. Now, after the coming up with the laboratory and the urine analysis, radiological imaging plays an important role where USG shows focal diffuse hyperechogenicity, thickening of the renal pelvis, and urethral dilatation. And a sensitive sign seen on CT is a reverse rim sign due to the normal medullary enhancement as well as hypoenhancing cortex. This reverse rim sign is different from the cortical rim sign, which is usually seen in case of renal infarction. After coming up with the diagnosis of pyelonephritis, IDSA has helped us in giving us the treatment protocol for UTI in 2010, which is still considered the gold standard, though many updates have been given later. When you come across with the symptoms of pyelonephritis, you see whether the patient is systemically well or unwell, depending given by many scoring systems, SOFA and QSOFA. Now, if the patient is well, systemically well, you treat them on an outpatient pathway. You give them an oral treatment for 7 to 14 days, which first line includes fluoroquinolones, ciprofloxacin 500 BD for 7 days, and levofloxacin 700 mg for 5 days. And we can also give cotrimoxazole if the local E. coli resistance is less than 20%. If the patient is systemically unwell, we decide to treat the patient on an inpatient pathway, have to admit, parenteral therapy should be given, where the first line includes penicillin along with an aminoglycoside. We can also give third generation cephalosporin and have to switch to oral after patient becomes afebrile within 72 hours. There's a norm that you should not use nitrofurantoin or oral fosfomycin of pivmavisilenam to treat acute pyelonephritis because these lack adequate tissue penetration in the upper tract. Why I'm giving emphasis on nitrofurantoin or oral fosfomycin? Because these are the treatment for the uncomplicated cystitis, where we give 100 mg BD nitrofurantoin for 5 days or a single dose of fosfomycin as a single dose for the treatment of uncomplicated cystitis. If we see a patient systemically unwell, we admit the patient, we follow the basic treatment protocols, eradicate pathogens, continuously monitoring blood glucose, blood and urine cultures, and we try to give them parenteral therapy until defervescence before considering a oral step-down regimen. We prefer to give penicillins, piperacillin, tazobactam 3.75 gram 6 hourly, along with the gentamicin 7 mg per kg. And if extended spectrum beta-lactam is suspected, we can give meropenem 500 mg TDS, ertapenem 1 gram IV 24 hourly. After an episode of acute pyelonephritis, if the treatment does not respond or if the treatment is not given, it may lead to pathological divergence into the scarred kidney. Chronic pyelonephritis may lead to gas-filled kidney, emphysematous pyelonephritis, or xanthogranulomatosis pyelonephritis, that is the lipid-replaced kidney, and also the last pus-filled kidney, that is pyelonephrosis. 4 pathological divergences are there. The first one is chronic pyelonephritis. This occurs when there is a tissue damage at the uterovesical junction, leading to the reflux of the urine and causing tissue damage. Important thing to note down is the scarring is never ever caused by sterile urine. It's always caused by an infected urine, and that's why early antimicrobial treatment can prevent architectural disruption. Patient presenting with reflux nephropathy will have 50% patients have elevated serum creatinine, 30% hypertension, and 35% proteinuria, raising the suspicion of the scarred kidney. After going through the investigations with functional imaging, management depends upon the results. Second pathology is emphysematous pyelonephritis, which is an acute necrotizing infection of the renal parenchyma by the gas-forming organisms. Diabetes mellitus is a very important risk factor for emphysematous pyelonephritis, where you have a high tissue glucose levels, which is poorly controlled diabetes mellitus. This causes invasion by the facultative anaerobes like E. coli or the Klebsiella, and this causes mixed acid fermentation, leading to the production of gases like CO2, oxygen, nitrogen, causes massive tissue infarction, leading to renal vascular thrombosis. It is a universal sign that you have to suspect emphysematous pyelonephritis in a case of acute severe pyelonephritis that fails to improve after 3 days of standard IV antimicrobial therapy. The diabetes ischemic cascade has been described in case of emphysematous pyelonephritis, where the patient is having uncontrolled hyperglycemia and immunocompromise. This through various pathways such as formation of advanced glycation end products, or sorbitol pathway, or reactive oxygen species, leads to the accelerated atherosclerosis, leads to the microvascular insufficiency, which is causing severely reduced blood flow to the renal papilla, causing renal papillary necrosis. So, an important point to note down is that the patient with emphysematous pyelonephritis is a diabetic patient and must be having oral hypoglycemic agent. So you have to avoid cotrimoxazole, which is considered the alternative in case of uncomplicated cystitis and UTI, because combination of cotrimoxazole and oral hypoglycemic agent causes profound hypoglycemia. Now, since the diabetic patients faces a higher risk of invasion by staphylococci and MRSA, you have to give vancomycin as a empiric coverage until the urine culture report comes in your hand. Management of emphysematous pyelonephritis depends on a Huang and Seng CT classification system, which has divided the emphysematous pyelonephritis into 4 classes. Class 1, when the gas is strictly connected to the collecting system. Class 2, when it extends into the renal parenchyma. Class 3, again divided into A and B. A includes perinephric space, 3B into the pararenal space, and class 4 is a catastrophic involvement of the kidney with the emphysematous pyelonephritis, solitary kidney, or a bilateral disease. When you come with the class staging of emphysematous pyelonephritis, management is easy. The class 1 and 2 will be managed by percutaneous drainage plus medical management. We already discussed vancomycin as empirical therapy until culture reports comes. In case of class 3, both 3A and AB, we evaluate risk factors which include shock, ARF, altered GCS, or thrombocytopenia. If there is 0 to 1 risk factors, we go for, there is a high chances of success with medical management and PCD insertion. But when you have more than equal to 2 risk factors, there's a high failure rate with medical management, and you have to go for the immediate nephrectomy. In case of class 4, we prefer to go for bilateral PCD plus medical management. And if they fail to respond, definitely have to go for bilateral nephrectomy and ICU renal support. The third pathology is xanthogranulomatosis pyelonephritis. It is also called as a perfect storm of infection and immune failure. It is a rare destructive variant of chronic pyelonephritis characterized by massive lipid accumulation and tissue destruction. Only 1% of the cases of chronic pyelonephritis develops xanthogranulomatosis pyelonephritis, and it usually targets middle-aged women with the risk factors of obesity, recurrent UTIs, and elevated creatinine. Patient present with a symptom triad of fever and chills, recurrent flank pain, and a palpable renal mass, therefore mimicking is at renal cell carcinoma, therefore also referred to as malignancy mascaradura. Lab findings include leukocytosis, anemia, and pyrene hematuria. The pathology is in 4 stages. The trigger caused by obstructed chronic obstruction and infection due to associated nephrolithiasis is seen in 83% of the patients, out of which 50% patients have stag-1 calculi. Now, this chronic obstruction infection is affected by bacterial colonization, the invader, where Proteus mirabilis plays a very important role and is a main culprit. Third is a lysosomal defect, where the macrophages ingest these bacteria but unable to perform a crucial phagolyzosome function, and therefore the macrophages become engorged with past positive granules, transforming it into a foamy lipid-laden xanthoma cells that destroy and replace normal parenchyma. The patient profile of xanthogranulomatosis pyelonephritis is seen to have a unilateral disease, predominantly affects middle-aged women 57 with the high-risk factors such as recurrent UTI, diabetics, ileus with obesity, and recurrent urinary obstruction. A very amazing triad of xanthogranulus pyelonephritis, which is seen in 50 to 80% of the patients. There's a unilateral renal enlargement. We can see a poorly functioning or absent renal function on IVP or functional imaging, a large calculus in the renal pelvis, 83%, which out of it 50% is stagnant calculi. Now there's a Beer's power sign. The central part of the Beers represents the massive stagnant calculi sitting in the renal pelvis, and the claws and toes represents massively dilated calyces with their parenchyma destroyed and replaced by yellow-orange xanthogranulomatous soft tissue. When we come up with the radiological diagnosis and we come up with the diagnosis of XZP, the surgical management is usually total open nephrectomy is indicated if the kidney is diffusely destroyed or if the malignancy cannot be ruled out. But though we know that XZP is notoriously difficult and it has adhesions with the surrounding structures causing high risk of injury, alternative has been suggested for focal resection if the pathology is localized to aiming to salvage residual functioning tissue, but the prognosis is very good because XZP does not recur after surgical resection. It is frequently mistaken for renal cell carcinoma, therefore referred to as malignancy masquerade. The fourth pathology is pyonephrosis. It's an acute suppurative infectious process featuring gross pus within the renal parenchyma, entirely secondary to the complete ureteral obstruction in the form of either calculi, strictures, or the congenital anomalies. USG will show persistent internal echoes or a visible fluid debris level, and is a surgical emergency requires immediate structural relief by USG or CT guided either PCD insertion or ureteral catheter. It has a diagnostic trap because the patient is presenting with a fever, chills, and flank pain, but there is complete lack of bacterial pyria because the infected system is completely sealed by the obstruction. This diagnostic trap feature is also shared by the renal abscess, which also shows urine culture normal, urine analysis normal, but is differential pyonephrosis because by the factor that it is a focal walled off cavity in the parenchyma, and it requires image guided drainage for source control as well. We have talked a lot about the CT. Now, we have to know whether is there any role of MRI in kidney infections or not. Yes, MRI plays a very important role in differentiating acute pyelonephritis from the abscess. Since MRI shows two important features, striated nephrogram, where you show the alternating bands of hypo and hyperattenuation along with the restricted diffusion. Now there's a term apparent diffusion coefficient, which is given on the MRI. Normal renal parenchyma shows a ADC value of 2, but in case of acute pyelonephritis, it comes down to 0.8252 to 0.95. This is differentiated from the renal abscess because it has an ADC value of extreme restriction coming down to 0.60 to 0.71 on MRI. And renal abscess can be distinguished from a severe and complicated acute pyelonephritis with a drop in the ADC, as well as the lack of central enhancement in the lesion with an hypoinflammatory hypervascular rim. And this allows for the definitive diagnosis and treatment without even the administration of gadolinium. So there are three universal axioms of the management. The first one is source control is paramount. We have to treat the abscess, drain the abscess, or we have to relieve the ureteral obstruction because antibiotic will not work in a closed, obstructive, or necrotic space. Second is strike hard and fast. In complicated hospital-acquired infection, definitely we have to go for the broad spectrum therapy depending on the local antibiogram immediately before the culture sensitivity reports comes in your hand. And third point is reassess after 72 hours. If there is a failure after 3 days of antibiotic in IV antibiotics and IV fluids, there's a universal red flag for a complication, and they have to immediately to assess for the complication in the form of abscess, emphysematous pyelonephritis, or the obstruction. We have a special population where the asymptomatic bacteria is also treated in pregnancy. The prevalence is though 2 to 7%, but if left untreated, may develop symptomatic pyelonephritis 20 to 35% of the cases, causing risk to pregnancy in the form of prematurity or the low birth weight. After coming up with the asymptomatic bacteria diagnosis, we treat it with 3-day course of single dose. So 3-day course or a single dose. We follow up the patient after 7 to 14 days. If the sterile culture is seen, we perform routine culture at each subsequent prenatal visit. If there is a growth or a relapse, we treat with 3-day course, or we can and we have to initiate the prophylaxis with cephaloxacin 150 mg BD until 4-6 postpartum, and you have to perform postpartum USG and KUB. There are several drugs which are used in kidney infections, but having a different roles in pregnancy, depending on the safety matrix. There are drugs which are safe in pregnancy, includes penicillin, cephalosporins, and macrolides. But those drugs which are strictly contraindicated includes fluoroquinolones due to risk of fetal cartilage and joint toxicity, and tetracycline, which triggers the maternal hepatotoxicity. There are some drugs which can be used with caution or dependent on the trimester of the pregnancy. Nitrofurantoin strictly avoided in the third trimester due to risk of G6PD deficiency causing neonatal hemolysis. Aminoglycosides contraindicated in second and third trimester due to fetal ototoxicity and nephrotoxicity, and cotrimoxazole avoided in the first trimester due to the risk of hyperemesis gravidarum in the third trimester due to the risk of kernicterus. The critical horizon lies in managing urosepsis. E. coli is responsible for more than 50% of the urosepsis cases. We have an urinary cytokine interleukin 8, which acts as a chemotactic protein to attract the neutrophils. Therefore, it can be used for the rapid diagnosis of impending urosepsis. It is crucial because blood cultures are only possible in 10 to 30% of the cases. And the resuscitative imperatives includes the normal, similar to the sepsis protocols, active fluid resuscitation, where you have to maintain the mean blood pressure more than 100, immediate empiric antibiotics according to the local antibiogram prior to the culture sensitivity, and immediate transfer of the patient to the ICU for multi-organ support capabilities. Now we have a next generation diagnostic arsenal in our hand in the form of biomarkers in the field of microbiology, in the field of imaging. Among the biomarkers, the purpose is to go for early risk stratification and the sepsis prediction. We have PCT, which is raised in the case of upper UTI, never in the case of lower UTI. IL-8 and 18 are the emerging cytokines. CRP and IL-6 serves to predict the severity and the systemic response markers. Neutrophil gelatinous social liponectin, NGAL, is used for early detection of AKI. And in microbiology, the purpose is for rapid pathogen and resistant identification. We have a PCR panels responsible for early organism identification along with the detecting resistant genes in SHS, extended spectrum beta-lactamase. We can directly go for carbapenems in that case. And next generation sequencing also helping us in resolving culture negative sepsis for better management. Among the imaging, we know CT is a gold standard, which is actually used in case of standard or complicated UTI. MRI plays an important role in differentiating pyelonephritis versus renal abscess via apparent diffusion coefficient value on the MRI. Contrast-enhanced ultrasonography detects microabscesses. Zero nephrotoxicity is preferred. AI imaging can also be used for automated information detection. Now, from the previous management therapies, there's a key paradigm shift in every type of pyelonephritis. In case of acute and complicated pyelonephritis, nowadays we follow antimicrobial stewardship. We give a 5 to 7 day course, which reduces the resistance without affecting the outcomes. Instead of 7 to 14 days antibiotic. In case of emphysematous pyelonephritis, there is a key paradigm shift from open surgery to minimally invasive surgery, leading to the reduction of mortality from 80% to only 13 to 20% with the modern care. In case of xanthogranulomatous pyelonephritis, since it is a malignancy muscular, so the multi-detector ECT scan distinctly separates xanthogranulomatous pyelonephritis from malignancy for minimally invasive planning. And in case of obstructive pyelonephritis renal abscess, nowadays we avoid open surgeries. There is an absolute prioritization of the early image-guided percutaneous intervention. This is the master diagnostic matrix of different types of pyelonephritis. Acute pyelonephritis, hallmark is patchy neutrophilic infiltrate, management by the fluoroquinolones, cephalosporins. Chronic pyelonephritis, shrunken and scarred kidney. You have to treat the underlying reflux after undergoing functional imaging. If the function is lost, have to go for nephrectomy. Emphysematous pyelonephritis, characterized by gas in the parenchyma. Management depends on the one and same criteria classification. Xanthogranulomatous pyelonephritis, we see the pus cells, xanthoma cells, and managed by open nephrectomy. Pyelonephrosis to be managed by immediate percutaneous drainage. So take-home messages: pyuria is paramount. A positive urine culture without pyuria likely represents asymptomatic colonization, not an acute infection. Therefore, always question the diagnosis. Second, match the bug to the drug. Since we know that E. coli is only causing major chunk in uncomplicated UTI, but in case of complicated UTI, there are other several organisms. Therefore, we have to mandatorily give a broader spectrum empiric coverage. Third is the image, the non-responders, severe pyelonephritis, failing to improve after 72 hours with IV antibiotics and IV fluids, should mandate an immediate imaging with a CT scan to rule out other causes in the form of obstruction, EPN, or an abscess. Emphysematous pyelonephritis requires aggression. That's why, however, avoidance from open surgery to minimally invasive, reducing the mortality to 13 to 20%. And pregnancy takes the exclusion, changes the rule, where you have to treat the asymptomatic bacteriuria to prevent severe pyelonephritis. Avoidance should be considered for fluoroquinolones and tetracyclines. Here we know the CT scan remains the absolute cornerstone for imaging complicated pyelonephritis, and early protection with the help of biomarkers is critical for early severity protection. Minimally invasive surgeries are being mandatorily involved over open surgeries for open abscesses, and we know that for first universal axiom of management, the early source control plus targeted antibiotics gives you maximum survival benefit. And the new standard includes antibiotic stewardship of 5 to 7 day course with a local antibiogram. And the clinical data, the new emerging trends in the treatment of pyelonephritis and genomic pathogen profiling, AI-assisted diagnosis, next generation antimicrobials, and immunomodulated therapies. Thank you.
Thank you, Rajat. And once again, anybody, resident or faculty, has any comment to make, most welcome. And those who have joined us, if they want to make any comment, they can raise their hands. So as usual, we will just summarize the whole thing, then have MCQs, comments from the moderators, and then wind up the session. So we all know urinary tract infection is the commonest bacterial infection, right, in the whole world. And we talked about UTI, and the severest form of UTI is acute pyelonephritis. We all know it starts with lower tract UTI. The infection ascends up through the ureter into the kidneys, and they can come present as acute pyelonephritis. Though hematogenous and lymphatic routes are also possible to cause acute pyelonephritis. So once a patient comes to the OPD, the basic clinical triad is flank pain, fever with chills, and vomiting, nausea, vomiting. They may not be associated altogether, but usually most of these patients would present with this triad. And then we have to be very careful, because this is not a very kind of a easy easy treatment to make. So some of these patients may have to be admitted and then treated. So we take a proper history in these patients, very important, whether the patient had any history of previous urinary tract infection, diabetes, any other surgery in the past, and other comorbid conditions. And then once we have taken a proper history, then definitely urine routine examination and urine culture should be sent immediately. If the patient is sick, morbid, then you send the blood culture also. Most of these patients, the diagnosis can be made clinically. Only patients who are very sick, complicated pyelonephritis, patients with stone disease, obstructed kidneys, they would require imaging study. So the simplest imaging study will be an ultrasound, though ultrasound can miss acute pyelonephritis in a good number of patients. So on ultrasound, what do you find? Ultrasound, you would find the kidney may be swollen, and there may be hypoechoic areas. It may be throughout, it may be focal areas. And when you do a Doppler, they will be hypovascular, right? Then there may be associated stone disease, the kidney may be obstructed, hydronephrosis, all those things can be seen on ultrasound. The best and the standard imaging study is the CT scan. So as a patient, we do not know the creatinine, we definitely would do a NCCT only. We have a creatinine, we would do a contrast enhanced CT scan. On NCCT, again, there is a enlarged swollen kidney, which is present there. And there may be some kind of perinephric fluid collection that may be visible. Stones may be visible on NCCT. And CCT scan, as he said, there would be wedge-shaped focal areas, right, which are have less HU values, and that will tell you whether this may be a pyelonephritis or not, right? And then there may be perinephric fluid collection also present, the perinephric fat standing. Usually in the venous phase, you find this poor enhancement of the kidney. And as he said, it can be differentiated from renal infarct by the REM sign, which is usually present on infarct, renal infarct, and there is a reverse REM sign in case of acute pyelonephritis, right? And then if you take an excretory phase, there will be a striated nephrogram, which is very typical of pyelonephritis. And if you take a film 3 to 4 hours later, then you can see there will be a delayed enhancement. So the dye will remain there if there is pyelonephritis, right? So these are some of the features on CT scan. On MRI, yes, again, on T1, there will be hypointense areas, T2, hyperintense areas. And then, as he said, diffusion weighted images, the ADC values goes down. So these are some of the features of MRI, which is done usually in patients who are pregnant, females. And then another imaging study is the nuclear medicine. Nuclear medicine is again important, where you do a technetium DMSA scan, which will show cold spots in the kidney. And this is quite typical of acute pyelonephritis, which is the usual standard nuclear imaging study. But there are other imaging studies like technetium glucoheptonate scan. And there is one called indium 111 WBC scan, which is done for infections, right? So these are some of the unusual or not usually required nuclear imaging studies. DMSA actually can tell whether there is kind of acute pyelonephritis or not. So when you talk about differential diagnosis, the differential diagnosis could be like interstitial nephritis. It has to be differentiated. It has to be differentiated from renal lymphoma. And then complications, we can have a focal nephronia. Sometimes there is a focal pyelonephritis, which results into focal nephronia, and later it can result into renal abscess also. So it can cause emphysematous pyelonephritis. As I said, sometimes it develops into XCP, xanthoglomerulomatous pyelonephritis, perinephric abscess, pyonephrosis. So all these are the various complications that can happen in the case of acute pyelonephritis, and definitely the patient may go into sepsis. And so the most easiest way to diagnose the sepsis is not only the clinical features, but also if you do a CBC, the NL ratio, which goes above less than 5, more than 5. So if the NL ratio is more than 5, you are sure that there is a sepsis is there. And then you can do definitely CRP and procalcitonin and NGAL and the IL-8 and IL-6, all those which are biomarkers for sepsis. When we talk about emphysematous pyelonephritis, he has already said it's a very kind of a acute condition. Previously, the mortality was very, very high. Now, with minimally invasive procedures, the mortality has gone down, and the incidence of nephrectomy in these patients have also gone down. We know the various types of emphysematous pyelonephritis, the Wensing classification, but usually the two main, one is less severe and the other is more severe kind of emphysematous pyelonephritis. And XJP, we all know, this is a granulomatous kind of a response to infection in the kidney. So between the cortex, just adjacent to the cortex, there will be lipid or the granulomatous response, and this is typically on histopathology. You get xanthorrhoma cells, which is lipid laden. macrophages. And most of these patients would require nephrectomy, right? Because they are almost a non-functioning kidney. I think that was, in a nutshell, the whole summary of acute pyelonephritis, which is a very important topic in your curriculum. And so I would request, anybody has any query? Any comment to make? Okay, Dr. Nilesh and Dr. Manoj, please. Huh? No? Okay.
Compliments to you. You presented the seminar quite well, a very crisp and timely presentation. And you covered almost all the important, relevant things that were to be included in this seminar. The presentation style was good, confident in your style. I hope you continue with it.
No. Very apt kind of a comment, because I also found it very good presentation in the sense that diagrammatic pictorial presentation, which was slightly different from the usual. And then the ending was also good. The diagnostic matrix and everything was good. One or few things I would have just given you as a prize if you could have just included some of the video clips. I find that in the YouTube, you can find many video clips of ultrasound imaging in acute pyelonephritis, CT video clips, which will show you the enhancement and poor enhancement and the rim signs, reverse rim sign, etc. That if could have been added, it would have been just icing on the whole presentation. So anyway, good presentation. So good. Thank you. So we will go to the MCQs. Go ahead, please. There's a different type. अपने आप होगा लेकर.
Sir, ask people to open the floor and join with the pin code.
Acha, you can ask.
Why is it connected to a server?
Yeah, that's what he's saying. So we are giving it in a different form now. So everybody has to open up their mobile phones and the pin open up with the pin number. Yes. कैसे क्या कौन सा pin number है क्या? Not getting connected to servers. So he said that he would try a new way of
sort of a quiz, right?
Sort of quiz, so that everyone can just
And we get to know how many people have answered it correctly.
Yes, sir.
Is it possible?
Yes, sir.
Yeah, good. Let's see. Now open up your mobile phones. Yeah, server का कोई issue आ रहा है? नेट
सबने इसमें लॉगिन कर रखा है, पहले से कर लिया होगा.
So
नहीं किया नहीं अभी क्या पिन आपको नहीं मिला ना नेट ऑन why it is not connecting? Can we just maybe we can practice it sometime. So again, anybody, if so, in the meantime, he gets connected to the MCQs. Anybody has any question? I would really kind of appreciate. Yes, Sarthak, go ahead.
Sir, when super nephrectomy has to be performed in cases of emphysemitis, is there any laws?
Yeah, that's what I'm. Previously, the threshold for nephrectomy was quite high. Because usually we would not do some kind of minimally invasive procedure like nephrostomy, putting nephrostomy. So previously we used to put nephrostomy only when there was a hydronephrotic kidney. Nowadays it is said that even if there is a collection, you can put nephrostomy tube, or you can put a tube to drain that collection, sometimes even stenting. So definitely with better antimicrobial coverage, etc., the mortality has gone down in emphysematous pyelonephritis. But the severe form of emphysematous pyelonephritis, as you said, if it is a solitary kidney or it's a bilateral kidney, or even if it is involving the perirenal, pararenal areas. And the kidney is totally destroyed. On imaging study, you will see that there is no parenchyma left. So there are cases, you will get cases where you will see that there is no parenchyma left. There's no enhancement, parenchyma is totally destroyed. In that case, definitely there is no other option than to do a nephrectomy. So when there is extensive parenchymal destruction with extensive involvement, you can see the gas around the pararenal areas, perirenal, besides in the kidney, then nephrectomy is the only option. Because if you don't do early nephrectomy, this sepsis can involve the other kidney also, and it can cause septicemia, and it can lead to multi-organ failure. It's very, very common. So still the mortality is around 30 to 40% in severe emphysematous pyelonephritis. So we have to be very careful in severe form of emphysematous pyelonephritis.
Your threshold for intervention in EPN should be very low. For the simple reason is that these patients are generally diabetics, they are immunocompromised, and usually they present in sepsis and multi-organ involvement. And as far as diversion or minimally invasive, stenting and PCN is concerned, you may not always, find some abscess or, collection where to put a stent, or sometimes you don't have any hydronephrosis at all. It is just, as sir said, enlarged kidney with gas and, all patches of inflammation and infection. So there is no actually space to put in a PCN or a DJ stent.
Yeah.
So start with IV antibiotics. Antibiotic coverage has to be very right from the word go. So you can't, sort of like escalate an antibiotic, start with a basic, multi broad spectrum antibiotic.
The question
You
escalate.
You have to be very aggressive right from the initial stage.
Pin bata dijiye.
And if the patient does not improve, then your nephrectomy threshold has to be.
So if I can just interrupt, the pin number is 598 42415. So 598415 is a new way we have trying to start for our MCQs, a quiz, which is mobile based. So all of you can open this quiz on your mobile phones, and you can see the question. So this is, I'm sorry that we are not being able to transmit it because on the laptop it's not coming. So this is a 40-year-old male, has persistent fever despite 5 days of IV antibiotics. CT shows a 4-centimeter rim enhancing lesion. Management. Continue antibiotics alone, immediate nephrectomy, percutaneous drainage, switch to oral antibiotics. So rim is a reverse rim, or it is a, it's an abscess, rim enhancing lesion, that's right. So what should be the answer? Yes. So come on, go back. Okay. So next time, Kappa. Which of the following virulence factors of uropathogenic E. coli is the most responsible for ascending infection? Lipopolysaccharide, capsule K antigen, hemolysin, P. fimbriae. So we had discussed it. So I think you should be ready with the answer. All right. So P. fimbriae is the right answer. Let's see what. Okay. So 700, which
4 people, 40 people, 7 people have correct.
7 people have made it correct. Right. Wonderful. So the next question is a 58-year-old diabetic female in septic shock. CT shows gas in renal parenchyma without fluid collection. Next step, emergency nephrectomy, IV antibiotics, strict glycemic control, percutaneous drainage, observation, oral antibiotics. So a case of emphysematous pyelonephritis. So now, as we said, yes. Answer is second. IV antibiotics, strict glycemic control, percutaneous drainage. So let's see how many were correct. How many?
No, three.
Three. Huh?
Six.
Six were correct. Okay, fine. Good. So patient presents with flank pain. CT shows wedge-shaped hyperdensity with preserved cortical rim enhancement. Diagnosis: acute pyelonephritis, renal abscess, renal infarction, XJP. Again, we have renal infarction. So rim sign is very typical of renal infarction. Reverse rim is for pyelonephritis. So how many are correct? Let's see. How many correct?
Only one.
Only one is correct. Captain Hacker. Okay. So in XGP, the bare pause on CT represents dilated calyces with inflammatory debris replacing parenchyma, gas formation, multiple renal cysts, renal artery aneurysm. So very, very easy. So definitely number one. So dilated calyces. So let's see, it should be 100% correct. Let's see. So how many are correct? Mama King. Okay. So six, how many cases? All are correct. Wonderful. All are correct. Good. So which of the following is the most appropriate indication for percutaneous drainage in acute pyelonephritis? Mild flank pain with fever, positive urine culture, presence of leukocytosis, renal abscess more than 3 centimeters or not responding to antibiotics. Again, very, very easy. Pyelonephritis doesn't need any drainage except this case, which is renal abscess more than 3 centimeters. So let's see how many correct. Okay, all are correct. Very good. So they have given the names also. One is Sister Nut, but who is Sister Nut here? Oh, you are Sister Nut. Okay. Okay, in given CT, the patchy cortical involvement seen on contrast enhanced CT corresponds histologically to diffuse glomerular sclerosis, interstitial edema with neutrophilic infiltration, tubular atrophy, vascular thrombosis. Patchy cortical involvement seen on contrast enhanced CT corresponds histologically to interstitial edema. All right, so let's see how many are correct. Okay, so 1, 2, 6 are correct, right? Captain Phone, Sister Nut is correct again. Good. A child with recurrent UTIs undergoes DMSA scan showing focal cortical defects, underlying mechanism of renal damage. Hematogenous infection, immune-mediated glomerulonephritis, intrarenal reflux causing scarring and tubular necrosis. Again, very easy. So VOR causes, so intrarenal reflux. So let's see how many. Oh, again, only except one. This Captain Hacker is always wrong. Who is Captain Hacker? Huh? A 45-year male presents with fever, flank pain, and oliguria. CT shows ureteric stone with hydronephrosis and signs of infection. Next step, ESWL, immediate ureteroscopy, IV antibiotics, urgent decompression, PCN or DJ stenting. Fever, flank pain, oliguria, ureteric stone, hydronephrosis definitely needs diversion, right? So urgent decompression. So let's see how many are correct. Mama King, okay. 1, 2, 3. Oh, good. 2 are still incorrect, huh? This fluffy slow. Fluffy slow is very slow. Okay. Which host defense involves a protein secreted by the ascending limb that binds type 1 pili to prevent bacterial invasion? Lactobacilli, gag layer, high urine osmolality, TAM horsefall protein. Gag? Which host difference involves okay, this is a TH protein. Acha. Acha, it involves a protein. Okay, so they asked about a protein. So definitely it should have been a protein. So fluffy slow this time is correct. Sister nut is also wrong this time. Good. Right. Final question. Final question has double points. According to IDSA, minimum CFU threshold for a clean catch specimen in a symptomatic woman with pyelonephritis, more than 10 to the power 3, more than 10 to the power 5, 10 to the power 5, any amount. IDSA is
Infectious Disease Society of America.
Infectious Disease Society of America. So minimum is 10 to the power 3. Is it? Oh, 10 to the power 4. So let's see how many are correct. So this has changed from 10 to the power 5 to 10 to the power 4. Okay. So, how many?
So result has been announced.
It's not announced.
Top 3 rankings.
Top 3 rank number 1. Nothing. Fluffy slow is number 1. My God. Fluffy slow. Who was fluffy slow? Okay. Mohit. Mohit. Okay. Love fast. Who was love fast? Oh, good. And third is freak data. Okay, Siddharth. Right. So the last was Sarthak. Kya ho gaya tumhe? So last was Mama King. Mama King. The host. The host has definitely 0. Dr. King. Who was Dr. King? Dr. King? अरे बोलने में कोई हर्ज नहीं है यार. And Sarthak was again one of the last ventures. Devashish was again Captain Hacker. Who was Captain Hacker? अरे बता नहीं रहे क्यों बोल रहे? Yeah. Sister Nut is in between.
What's the topper?
Topper is Fluffy Slow. Who was Fluffy Slow? Mohit. Mohit and you. तुम्हारा क्या नाम है? Ayush. Okay. And Love Fast? Ashish. And Freak. Freak is Siddharth. Chalo, good. So I like this. So we can do it. Let's see why it didn't come here. So, but now I've changed my mind. Okay. So, but how to put it here? I've changed my mind now. Right. So I don't have a 500 का note है मेरे पास.
इसको वो कर देंगे ना सर यूपीआई कर
नहीं यूपीआई नहीं मेरे पास 500 रुपया था. 5
आजकल कैश तो
5. Good.